My name is Salim Hirani, and I'm a chief clinical physiologist, neurophysiology, in working in neurophysiology for more than 32 years. So, and I did many, my research paper has been published, most of them. And I noticed that while I was recording and conducting that research, I noticed that some of that information at present, in especially in UK, it is not properly graded, like for carpal tunnel syndrome and ulnar nerve entrapment. So I work especially on these two of them. So my research paper already published in on both of them. You can and it is available on Google as well. So you can just try to get it and for further understanding. Okay, so come back to that this ulnar nerve entrapment. Ulnar nerve entrapment basically it's a three level. Mostly, normally people knows about that. Okay, only for cubital tunnel, which is across elbow, but actually it is on Guy's canal as well, and under the Guy's canal and near to the palm as well. There's two other branches, which is the superficial branches and that mid palm as well. So these are the four areas where it will be blocked and causing the problem to the ulnar nerve. And because of that, these are very unique areas, and the Guy's motor area as well, which is very rarely you can see that one. And I have some experience in this one. I have the data as well. I will show you in a minute. So I realized that because the surgeon, when the patient goes to the surgeon or orthopedic, they normally what they have to do that, oh, you have a problem in the ulnar nerve, and they operate that the cubital tunnel, and patient have the same problem because the problem actually it is at the wrist or below wrist, and that is the reason that a patient can come back again with the same symptoms. So that's why I this my all my research paper and all this presentation is according to these areas. So as I mentioned, there's a two type of entrapment, which is at the wrist and below wrist. Type one is called proximal compression of the Guy's canal, which is a very rare cases where compression causing the not only the sensory but also the motor part as well. So that is I saw in last, just imagine, I saw in last 20 years only three cases with that where that sensory involvement and the motor weakness as well. Another one is that which is called type 2, which is least common, but still it has a problem as well. And it that is called superficial branch of the distal portion, where that the cutaneous nerve territory is involved due to that muscle or the bony structure. So as I mentioned, the proximal compression of that Guy's canal lead to motor weakness in all the interesting muscle and to hand, which is the innervative or the ulnar nerve. There are sensory loss in the territory of the hand where serves by the ulnar nerve. And in that motor case, which is type 1, give me a second. There's a noise outside. Give me a second. Sorry for the disturbance. So that is because the motor nerve involvement. So normal nerve conduction shows a prolonged distal motor latency with that amplitude, with the normal amplitude and slow conduction velocities as well in both sensory motor conduction. In type 2, the least, which is least common, as I mentioned, which is a superficial branch of the ulnar nerve at the distal portion of the Guy's canal. It is almost look like the symptoms are same like type 1, but the only difference is that in type 2 that conduction velocity in sensory is slow conduction velocity. As compared to that type 1, there is no slow conduction in the sensory. In this one is all of them are slow, like palm to wrist, digit 5 to wrist, dorsal ulnar cutaneous as well, slow as well. So according to this one, when we collected the normal data, we put them to very easily to understand that 5 microvolt and 5 millivolt for the amplitude, and the conduction velocity is 50 meters per second for motor and sensory, both of them. The distal latency in motor latency is more than 4.5 millisecond in ulnar nerve because the distance is different. And these are the values was collected by department and according to the BSCN, which is British Society of Clinical Neurophysiology Sciences, and there's an ANS, Association for Neurophysiological Sciences. They have published their guidelines as well, which is actually there's a lot of loopholes in that one as well, which is now they are working on it. This is that the link is available as well. Okay, because the slides are not working, otherwise I will show that there's a lots of research paper has been published on different level of entrapment, but most of them are talking about either wrist area, which is Guy's canal, or either at the elbow. No one is talking, none of the research paper has talked about the entrapment below wrist, and the double crush syndrome of the entrapment of both of them, Guy's canal as well, below an elbow wrist as well. So none of them. So my paper is unique, which discuss all of them in one go. And this is the paper which was published in a Journal of Brain and Research and Neurology, which is available. If you can take a picture and then you can look at it, which is free of charge. You can view that one. During this entrapment, as I mentioned, that the research was, they have done it, many researchers, and they talk about either wrist, which is either they grade them 2, 3, 4, or 5. And same as it is across elbow, 3, 4, 5, and 6 grading system, but none of them are comparing, as I mentioned, and especially none of them did that the lesion between 5 to mid palm to wrist, which is causing many patients who are using either a bike or plier or riding or walking stick, like that old man, they are using walking stick. These are causing the compression at this area, which is the Guy's canal area. So according to this one, now I will discuss about my grading. So it will give you idea that when I'm going to show you my my case, so you will have some idea about that one, how it was grading them. So in grade 1, which is ulnar nerve entrapment between digit 5 to mid palm, which is the distal compression at mid palm due to local compression of the sensory, which causing this numbness in digit 4 and 5. Normally in nerve conduction in this one, there's no entrapment across both motor and sensory, across wrist, and nerve conduction only compression. There's a low amplitude between digit 5 to wrist and mid palm to wrist, and with the dorsal ulnar is normal. So and with that motor conduction velocities, wrist and across elbow is normal. So there's only compression, there's a sensory compression at the mid palm, because these people are normally use stick or riding or that DIY. In second grade, which is called most common, which is people knows about that one, is Guy's canal, where the compression at the wrist, lower wrist, and this is symptoms are almost type 1 type. However, there's only the sensory branch of dorsal part of the hand is motor supply, which is unaffected in this grade, as compared to the grade 1 type 1. There's a compression of the motor part as well. So nerve conduction normally low amplitude in digit 5 and digit 5 to wrist with normal conduction velocities, in sensory, and nerve conduction of dorsal ulnar cutaneous nerve shows normal amplitude and conduction velocity. In grade 3, which is across elbow, in the early stage, where motor conduction velocity is less than 50 meter per second with in FDI, and ADM with the normal distal latency and amplitude and conduction velocity. Uh, and sensory potentials are normals, wrist, across wrist and below wrist, all are normal. So there's a very early stage. As you know that FDI is more sensitive as compared to the ADM. That's why FDI will find this early changes in the across elbow. Then grade 4, please do not think about this grade grade numbers which is higher, just only to understand that the grading to differentiate between those levels of entrapment. In grade 4, that which include both FDI and ADM, and that's why it is a mild stage where the conduction velocity is between 41 to 49, same as it is in this early stage as well, between 41 to 49, but only FDI involvement. But in this one, grade 4, ADM and FDI both are involved. And this after that one is that moderate sensory motor, where the conduction velocity between across elbow, which is 30 to 40 meter per second, with the normal latency and normal distal latency. Low amplitude sensory potential could possible between mid palm to wrist, and with that normal across the wrist. Dorsal ulnar cutaneous has normal amplitude and conduction velocity. In grade 6, which is severe case where the sensory and motor both are involved, where the conduction velocity either it is less than 30 meter per second, and the distal latencies are either absent or with the low amplitude in all of these cases, and palm to wrist, across wrist, and dorsal ulnar cutaneous wrist. So now I will go for the history cases, so you can understand more understandable that with the values. This patient was diagnosed as a left golfer elbow. Patient presented with numbness in digit 4 and 5 of the left hand, with pain at the elbow for last 3 to 4 months. No paresthesia in the right hand. The problem in only in the left hand. Also, left shoulder and neck is symptom free, so there is no problem. There is no history of diabetes or arthritis or any infection. So when we did the nerve connection with the ulnar median nerve, which is normal, ulnar sensory amplitude is normal, but you can see that when the conduction velocity from digit 5 to wrist and palm to wrist is less than 50, so 44 and 46. So that is compression at that level. Motor area where the distal latency of the median nerves are around normal, amplitude is normal, and conduction velocity is normal. When we did the FDI, there is a distal latency is 5.89. Our normal value is 4.5, and same as it is 5.23. So it is a slow conduction, prolonged distal latency with normal amplitude. There's a Martin Gruber, this patient as well, that this amplitude is dropped in below elbow, and it is recorded from median nerve as well while recording from FDI. Conduction velocities wise, which is normal. So there's a distal latency prolonged, and sensory conduction velocities are prolonged with that cutaneous nerve, which is normal as well. So there's the involvement of the, this is goes to the sensory motor Guy's canal entrapment, which is type 1. There's also evidence of Martin Gruber, which I mentioned. So which is type 1, which is because of the motor involvement, proximal compression of the Guy's canal lead to the motor weakness. So this patient can be treated with that surgical treatment, which help to the release the nerve. So case 2, this is a patient presented with constant numbness in digit 4 and 5 of the left hand For past 3 to 4 years, patient had decompression of the left ulnar nerve at the elbow 2 years ago, and the symptoms still persisted. See, this is the case which is very interesting. Both hands numbness, get pain, neck has limited movement, and no history of diabetes or arthritis. So this patient, we did the sensory median, which is normal, right side also normal, ulnar nerve, which is low amplitude from digit 5 to wrist, and other side which is normal and with the slow conduction velocity. And when we did the dorsal ulnar cutaneous, which is also slow, low amplitude and slow conduction velocity. Then when we did the motor part, median are normal, ulnars, which is distal latency is normal with the normal amplitude and normal conduction velocity. So there's a compression below wrist, and which is causing this is that which is type 2. That's a superficial branch of the Guy's canal. So you have more idea that if it is a superficial branch of the Guy's canal, it will show this type of compression of the nerve, which is only the sensory nerve involvement. So this is list, as I mentioned, is common Guy's canal syndrome causing superficial branch of the ulnar nerve. This type of result loss of sensation from the cutaneous territory and hand which served by the cutaneous nerve. And you can see this patient has no motor nerve infection, motor nerve function impairment. So, and this patient was treated at the elbow entrapment, which is nothing will happen. So this patient only need a conservative treatment for physiotherapy or maybe steroid injection at the wrist, which can help to release the nerve. So that entrapment was done for this patient. For surgery was useless. So now third case, this is 82 years old right-handed retired male presented with electric shock and pain from both shoulder to all fingers with burning sensation during sleep for past 6 months, no history of diabetic or arthritis, and has a good hand grips. So when we did the test, median amplitude is median amplitude is slightly low amplitude in both of them and slow conduction velocity. So the patient has some median nerve entrapment as well. And that ulnar nerve, palm to wrist was fine, but digit 5 to wrist was low amplitude with normal conduction velocity. Other side amplitude is fine and conduction velocity is normal. So motor, we can see that we can see now. So median sensories are normal with normal amplitude and conduction velocity. So there is only entrapment of the sensory involvement of the median nerve. And now we'll look at it that ulnar nerve, which is distal latency is normal under 4.5, all of them, and conduction amplitude wise as well, all above 5, and conduction velocities are all normal as well. So there is a compression around below wrist. This is because palm to wrist is normal. So the conduction velocity, the nerve conduction is study shows that grade 2 carpal tunnel syndrome in both sides. In addition, there is evidence of left ulnar nerve sensory branch at the mid palm is affected with no entrapment across elbow. So this is grade 1. So it is involvement entrapment below between digit 5 to mid palm. So this patient can be treated with that conservative treatment, which will be solve the problem. Patient now case 4, which is patient presented with the intermittent numbness in digit 5, 4 and 5, and pins a needle in to the left wrist with odd pain at the elbow since 2000 May 2017. No paresthesia in hand, occasionally neck stiffness. There is no history of diabetes or arthritis or an infection. So when we did the median nerve, which is normal, ulnar, which is showing that palm to wrist, and digit 5 to wrist, which is low amplitude, but dorsal ulnar cutaneous nerve shows normal with normal conduction velocities, which is shows in blue. Ulnar nerve normal amplitude, normal distal latencies, sorry, distal latency normal, amplitude is normal, and conduction velocity is also normal. So compression at the rest, which is causing the low amplitude in digit 5 to rest and palm to rest. So this is called Guy's canal, which is very well known case, very common Guy's canal problem, and which can be treated with the conservative treatment. This patient is a follow-up. Previous study was normal, but clinically some irritation around the left elbow. At present, patient gets pins and needle in digit 1 to 4 for basically, if you can look at it, 1 to 4, which is the median part of the left hand, and that is radiate to the biceps muscle. Patient symptoms stay the same all the time since November 2010. Past 1 week, patient feel little better, no symptoms in the right hand, and no other medical history. So when we did the nerve conduction, this amplitude wise, all are normal. This is the we are did the double peak because to see that whether a patient having any early sign of carpal tunnel. So those are all nerve above amplitude are all normal, and conduction velocities are all normal. And the motor part, if you can see that one, the median nerves are normal. Uh, Ulnar nerves, distal latencies are all normal, amplitude-wise as well normal, but only there's a slow conduction velocity across the left elbow, where as compared to that in FDI and ADM is normal, other side is normal. So there's a compression at the left FDI, so which is part of the early ulnar nerve entrapment of the left elbow, which can be, this patient can be treated because only early stages. So this patient can be treated with the conservative treatment by steroid injection or maybe some physiotherapy or giving a splint to try not to bend his patient. Patient will not bend the elbow, which help to the ease of that problem. Uh, this patient is 46 years old. Patient presented with intermittent numbness and pins and needle start from both shoulder and spread to fingers, especially to digit 4 to 5, left more than right as for since last long time 2011. Patient had a road traffic accident in 2010, and patient gets pain around the neck and has a left frozen shoulder. No history of diabetes or infection. So sensory amplitude, which is normal both side and normal conduction velocity. Ulnar amplitude, which is above 5, which is normal. Conduction velocity is normal. Distal latency under 4.5, which is also normal. Amplitude wise, all are normal. Conduction velocity medians are normal. Ulnar, there's a entrapment at the left elbow, which is 45, and ADM and FDI, both of them, and the right side is normal. So there's a compression because it is involved more, both of them, both median and both ulnar, FDI and ADM over the left side. So which is called the mild case of ulnar nerve entrapment. And this patient can be treated with the surgical treatment that help to ease off that the muscle nerve entrapment across elbow. This patient is presented with the contracture of the left digit 5 of the left hand for past 4 to 5 years, and patient get pain as well. Patient also get pins and needles and in the left arm, left palm and forearm for past 3 months. No history of diabetes or history of diabetes for 13 years, and patient is on tablet. There's no history of arthritis or an infection across elbow. So when we did the test, amplitude in digit 3 bilaterally normal with normal conduction velocity in median side, digit 5, which is amplitude to digit 5 to wrist was low, but palm to wrist was normal with normal conduction velocity. And other side, digit 5 to wrist and was normal. So motor, distal latencies, median both normal, palm to digit ulnar is less than 4.5, which is also normal. Amplitude-wise, all are above 5, and the conduction velocity median are normal, and digit, 5 to raise, FDI shows that across elbow is less than 40 meter per second in the left side, and the right is 43, so that is mild case, and the left side is moderate. So there's evidence of mild right and moderate left ulnar nerve entrapment. This patient, because the involvement of both FDI and ADM, so patient can be treated with the surgical treatment with help to ease of that patient problem. This 73 years old retired male presented with constant pins and needle at the tip of all fingers and pain around the thumb to forearm bilateral for a long time, 2015. This patient have no history of diabetes but history of arthritis, and and patient had a steroid injection at the left shoulder. So when we did the test, median nerve amplitude is normal, and conduction velocity is slightly, it is slow, and ulnar nerve is absent on the left side. Right is low amplitude with palm to wrist, digit 5 to wrist was slow, and but palm to wrist was normal. So that's a mid palm to wrist, mid palm has some problem, but amplitude is also low. Then we did the dorsal ulnar, which is also absent on the left side, but other side, right side, it is normal with slow conduction velocity. So median nerve, you can see that one here as well, some slow conduction velocity, and here as well it is slowing that prolonged distal latency, that it is problem. Patient having entrapment of the bilateral moderate CTS as well. FDI distal latency 3.4 to 3.6 in or 2.85 and 3.05, which is normal with the normal amplitude. Conduction velocity is, you can see that one below 30, which is severe case on the left side, and right side is 32, 39, which is moderate. So severe over the left side, as you can see that one, that absent as well response. So this patient is a great, as I mentioned about the moderate bilateral grade 3 bilateral median nerve dysfunction. And also there's a severe left and moderate right ulnar nerve dysfunction. And this patient can be treated for both median nerve and ulnar nerve for the surgical treatment, can be helpful for this patient. So I just want to give you a glimpses of after the glimpses of that all the cases, the normal values. So you can see that one, normal values, and the grading, which is according to my research, we set up this grading. I'll give you time to look at it. One thing more I just want to add here, that I noticed few of the research talk about the amplitude drop across the elbow, but in my research there is a lot of cases, I think so, around 1,000 cases, and out of that one only I saw a drop of amplitude only in basically grade 5 and 6 in between, where the amplitude drop above 40% or 50%. Otherwise, although I put them as a 30% in grade 4 and 20% in grade 3, but there's no dropping of amplitude across in these areas. If the ulnar nerve is not recordable in motor as well as sensory, uh, in all palm to wrist, across wrist and dorsal and cutaneous nerve and across elbow, then this patient was considered as a complete ulnar nerve entrapment, and this patient will proceed to for the further needle examination with the consultant. So they can look at localize the entrapment maybe above elbow, around shoulder or neck. So these are the grading. It's one page, so you can see that one. You can take a picture as well if you want to take a. So the conclusion. So despite the relativity of a small region of involvement of ulnar nerve entrapment at or below wrist, it has been wide range of clinical presentation that may result in frequent misdiagnosis. And you saw that one clearly, that one of the patient has was operated across elbow, all the patient having a problem at the wrist. So that's why accurate neurophysiological examination, knowledge of ulnar nerve and the wrist anatomy, and familiarity with the possible clinical pattern are essential to making the diagnosis, which then can be confirmed by with the neurophysiology test. Low amplitude sensory potential between digit 5 to mid palm, normally ignored by most of the orthopedic because of uncertainty, and the research, no research was made in the past, as I mentioned to you. Compression between conduction block across elbow and drop off amplitude across elbow in ulnar nerve entrapment. Conduction block shows almost 90% and only 10% drop off amplitude, which I mentioned to you, that most of them conduction block is more patient having that conduction block as compared to the drop off amplitude across elbow. And slow conduction velocity in digit 5 to mid palm and digit 5 to wrist is very rare cases, which I got 2 or 3 cases in 25, and recently I got one more case, and could need to look at it for other medical cases. And complete loss of sensory loss of motor potential is not included in this grading system. So there is some suggestion. The grading system devised by the research across elbow and across wrist. One more thing I just want to tell you, that I didn't include it in this. I didn't present it because of the time constraint about that the double crash syndrome, the wrist and across elbow. But in my research, all of them are involved, included in that according to that quantity of the patient as well. So the suggestion in this one, that the grading system devised by the research across the elbow or across the wrist to grade them for the severity of ulnar nerve are very old, and this need to be rephrased, and research has to be has to be done, and more research to be work on it. This system needs modification in order to accommodate to current practice conducted by the clinical physiologist. It is proposed that all neurophysiological association include British as well as American, and also from the eastern side, need to be work on this new grading system and make an international standard for ulnar nerve entrapment. As I mentioned, it is proposed that type 1 and grade 1 to 3 may refer for conservative treatment, and type 1 and grade 4 to 6 may refer for surgical treatment in their respective areas. So these are some grading which is available to understand, for that which is published by different people. Mostly people are following this Padua grading at present. So, but that's a lot of miscommunication here as well. Any question? If I will put them back this so you can look at it. Yeah. Thank you for giving me a chance to present my presentation.